Welcome to this video on Melioidosis, the Great Mimicker. We will cover the epidemiology, basic sciences, clinical management, and surgical perspectives of this infection. Melioidosis is traditionally concentrated in the endemic belt of Southeast Asia and Northern Australia. Its geography is expanding, and modeling suggests a silent burden of up to 165,000 annual cases worldwide, often misreported as TB or pneumonia. This map illustrates the global distribution of melioidosis, highlighting the areas where the disease is endemic or sporadically reported. Environmental drivers are key to its transmission. Seasonality sees a spike in cases during the rainy season. Extreme weather events like flooding aerosolize the bacteria. Climate change is predicted to expand the geographic range of endemic areas. The causative pathogen is Burkholderia pseudomallei, a gram-negative motile bacillus. It has a characteristic safety pin appearance on gram stain and thrives in moist soil and water. Its virulence stems from a type 3 secretion system, enabling it to spread cell to cell. This is a transmission electron micrograph of flagellated Burkholderia pseudomallei, magnified to a 1 micrometer scale. The hallmark of melioidosis pathology is abscess formation due to pyogenic inflammation. Transmission is commonly percutaneous, but can also occur via inhalation or ingestion. Importantly, the bacteria can remain latent within macrophages for years. Pharmacologically, B. pseudomallei is intrinsically resistant to many common antibiotics. The gold standard for intensive therapy is ceftazidime or meropenem for septic shock. Trimethoprim sulfamethoxazole is the key agent for the eradication phase. Melioidosis is known as the Great Mimicker due to its varied clinical presentations. These include acute pulmonary infection, rapidly fatal septicemia, and localized infections like skin ulcers and parotid abscesses. Chronic melioidosis can often mimic tuberculosis. Here are examples of localized skin ulcers associated with melioidosis. Parotid abscesses are another common localized presentation, particularly in children. Melioidosis is an opportunistic pathogen. Major risk factors include diabetes mellitus, chronic kidney disease, and excessive alcohol consumption. Occupational exposure, especially in farming and construction, is also a significant risk. The gold standard for diagnosis remains culture from any site, using selective media like Ashdowns. Imaging, such as CT/ultrasound, is crucial for detecting, quote, silent visceral abscesses. Serology is common, but can be unreliable in endemic areas. This image displays Burkholderia pseudomallei colonies growing on Ashdowns medium. A chest X-ray in a melioidosis case may reveal right pulmonary consolidation with cavitation and a gas fluid level. Small cavitating nodules in both lungs may also be present. A chest CT scan in melioidosis often shows consolidation, such as in the right upper, middle, and lower lobes with air bronchograms and cavitation. Multiple small nodules, ground glass opacities, and mediastinal lymph node enlargement may also be present. Hepatosplenic melioidosis often presents with multiple lesions in the liver and spleen. In the liver, these may appear as multifocal abscesses with multiple septa and a honeycomb appearance on quart. Prostatic abscesses are another common manifestation. Imaging may show an enlarged prostate gland with loculated hypodense lesions and mild periprostatic inflammatory fat strand. Due to the risk of laboratory-acquired infection, B. pseudomallei is classified as a biosafety level 3 agent. Routine labs may misidentify it, so any gram-negative bacillus with safety pin staining from a sterile site in a traveler from endemic areas should be handled under a biosafety hood. Treatment is divided into 2 strict phases. The intensive phase lasts 2 to 4 weeks, using intravenous ceftazidime or meropenem. This is followed by the eradication phase, lasting 3 to 6 months, using oral TMPSM to prevent relapse. In general surgery, drainage is often required for large abscesses, typically those over 3 centimeters in the liver or spleen. Prostatic abscesses often require transurethral resection or drainage. Melioidosis can affect surgical subspecialties. Orthopedics deals with septic arthritis and osteomyelitis. Urology manages renal cortical abscesses. Neurosurgery may treat brain abscesses. In pediatric cases, ENT is often involved due to acute parotitis. Prevention focuses on PPE for workers in endemic areas, emphasizing waterproof boots and gloves. Healthcare workers should use standard precautions. Water safety is important. An awareness campaign should target high-risk groups like diabetics during the rainy season. Key takeaways include always screening for diabetes, the most significant risk factor. Surgery is an adjunct to long-term antibiotics. Maintain vigilance and consider melioidosis in patients with sepsis and a travel history to the tropics. Thank you for watching this video. We hope this information helps you study, reflect, and improve your knowledge of melioidosis.